must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Are you a third-year physical therapy student that excels on tests when you have study guides, checklists, and deadlines? With all of the information available about how to prepare for the NPTE, it's easy to get disorganized and not feel prepared going into the big day. NPTE Prep Success is an online course that provides PT students easy-to-use study guides and step-by-step guidance through the NPTE preparation. To learn more, visit kylericeprep.com. Thank you again all for your continued support. And now for the show. Hello, everyone, and welcome to another episode of the Healthcare Education Transformation Podcast. Thank you for listening. Of course, I am Brandon Pullen, and I am joined, as always, by my fellow co-hosts, Stephanie Wyrock and F. Scott Fiel. And today we have the esteemed pleasure of welcoming a very special guest on the show today to talk about evidence-based orthopedic and pain practice, and also how to improve education. As today we welcome Dr. Erik Meira, who is a physical therapist with Black Diamond Physical Therapy in Portland, Oregon. And he has also created and oversees the PT Podcast Network and the PT Inquest Podcast. And he is extremely active in the sports section of APTA, serving on the membership committee since 2005. And since 2012, he has been the sports section program chair for the combined sections meetings. So, Erik, first and foremost, thank you so much for your dedication and work to the PT profession and for coming on the show today to really speak with us, as it's truly an honor to have you on. Do you think you could kind of tell our listeners a little bit of your background and who you are and to kind of your journey and how it led to where you are now?
I think you introduced it pretty well. First off, thank you guys very much for having me on. I really appreciate the opportunity to chat with you guys. I've been a physical therapist for just over 20 years now. Back when I got my degree, it was the bachelor's program, so it's come a long way since then. I started in neurosurgery centers where I worked originally over at George Washington University Hospital in Washington, D.C., and then spent some time building my own practice focused on sports medicine. And, as you said, I'm very active in the sports physical therapy section. I can credit them with a lot of my personal advancement. And then I've just been trying to give back to them as much as possible as well.
You mentioned, Erik, that when you started physical therapy, it was a bachelor's degree. Now it's a doctorate degree. You've been a PT for 20 years. Could you walk us through how your clinical beliefs about pain and structure, exercise, biomechanics, any of those topics have evolved since you came out of school? Because I'm sure that gaining some of this clinical experience has really changed maybe how you've thought about clinical problems.
Well, that's an interesting question to ask me in particular, because back I graduated in 1998. My senior project was actually on the behavioral components of pain. So it happened to be that was something I was at the University of Florida. They were, they continued to be a kind of a pioneer in that setting. And that was something that they were, different instructors at the time, but were toying with a little bit. And my whole thing was on the association with back pain and behavioral type situations, and looking at interventions like operant conditioning and things like that. So I had that in my last clinical as well, because I went to the big teaching hospital at University of Florida for my final rotation in outpatient orthopedics, and did a lot of graded activity, graded exposure, again, operant conditioning. But then when I got out into practice, it wasn't there at all. So it was just interesting because I was coming in with my toolkit that I had, and I've always been very heavy, and maybe this is also credit to my training, very heavy in citations and reviewing research and all of that. And so when I got into clinical practice, it was very confusing to me why these things weren't being done even back then. And then having it kind of dumped down on me of, well, you're new, you don't know what you're doing here. Trust me, just do it our way. And this is going to be the way to do it. And it was very much that, pain had to do with some sort of a structural problem, which, as we know, it definitely can be associated with that, but by no means is all pain like that, especially when you get into more into those non-specific categories. So I've enjoyed seeing that change over time, more in the clinical setting, seeing it more in school, I think. I mean, again, because my program was already kind of pretty big on that back then. But definitely in the clinical setting, seeing that change over the years has definitely been very interesting to watch.
I think it's really interesting, Erik, that you said, you came out of school, you got into clinical practice, and then the stuff that you were learning that was evidence-based, people weren't really applying it to practice. We have a lot of listeners that listen to our podcast who are newer clinicians. What advice would you give them if they are in their new job or at a clinical rotation and they notice this in their clinic?
Well, there's a couple of angles that I've heard the advice from other people as well, as because some people say, hey, you know what? This problem can be solved by new grads, being that new grads should be challenging their supervisors and their mentors and as students even to be challenging their, during their internships, challenging their clinical instructors. And I would say there's a big power dynamic that I don't think would be very useful. And remembering back when I was a student and also as a new grad, there was a power dynamic there that just didn't really allow that type of challenge. That said, you are a licensed professional who is autonomous. You do not have to practice as you're told, because ultimately it's your license on the line. You need to be able to stand up for what you do. Now, the conversations I remember having, I had a supervisor, specifically in outpatient orthopedics. Again, my first job, I did get to bounce around in acute care. Neurosurgery was my heavy dose of it there, but also in inpatient rehab, so like acute rehab, and then also in the regular old outpatient orthopedic clinic. And my outpatient orthopedic supervisor, I remember everything was going fine. The patients loved me. I was getting great results. No problems whatsoever, until one day they did a chart review and they looked in my charts and they were like, what is, why aren't you doing all these other things? Why are you just basically having them do like a graded exposure program? And I was like, well, because the evidence shows this, that. And the supervisor said, well, look, I've got 30 years of experience that tells me these other things here work. And I said, that's great for you. I don't have 30 years of experience, so I have to rely on this evidence base that I have. And that was the thing that really kind of established me in that setting of kind of allowing me to dig my heels in a little bit and just go, look, I appreciate that you do what you do based off of your experience, but I don't have that experience base really to go on.
Yeah, Erik, in the world of orthopedics, we know you have a special fondness for the knee as far as teaching, but what are some of the most important things that a clinician should assess and consider when treating a person with a knee pain or disability based on the best available evidence out there?
Well, in general, when assessing a patient, I kind of have a part of the sports medicine world is we have to do a lot of emergency medicine. So we do a lot of like for sideline management, those types of things. And one of the things that we're taught with emergency medicine is kind of a hierarchy of assessment. So you have a primary assessment, make sure their airway is open, they're breathing, they have circulation, the basics. And then you go to your secondary assessment where you then go through and, okay, I made sure the major stuff isn't a problem. Now let me go to the secondary and go to the next kind of hierarchy of that. And so I kind of see that the same thing when approaching any patient in general. So the first thing is, your primary assessment. And to me, in a PT type setting, my primary assessment is going to be asking the question, is this something I should be treating, or is this something I should be referring on to somebody else? And that's really the number one thing I'm looking for. So is this, somebody actually has a fracture that they just think is a swollen knee or, things along those lines. And then that secondary thing is then, and again, looking for structural damage. They've blown out their MCL, their ACL, just doing, those basic special tests to look for very serious things that not necessarily saying surgery is required, but saying they need a consult with a surgeon to have that conversation as to what their options are and make sure that the patient is truly in control and I'm not hiding them from anybody. But then after all that stuff is cleared, then it really comes down to, trying to figure out where the patient is. I like to call it looking at where the patient is physically, mentally, and emotionally. And so, physically, that's the easy one. We use dynamometers in our clinic. So how much force can you put out? Like if it's somebody's knee, I want to know how much their quad can put out. So we'll set a dynamometer. I'm kicking to the dynamometer. There's your number compared to the other side. You're 50% of your other side. We need to come down to where you are with your injured side and bring you up to what your uninvolved side is. But then mentally, hey, what do you think is going on? What is your education as far as this process? I mean, do you think you're damaging your knee because your patellofemoral joint is hurting? Do you think that this is something you can't train through? Do you think that this is, do you think that there are aliens who have set up shop in your knee and they're creating a new life form that's going to come emerging? Again, whatever the patient may be thinking, I need to come down to where they are. And then just like I do with the load tolerance, I need to build that up. And then of course the emotional part of it too. Are you dealing with a high school athlete who's staring down a college scholarship, and this injury may be taking them out of contention for it, and they're really starting to reel because they don't have financial options otherwise. This is their only opportunity to go to college, and they may have just lost that. Or you have a freshman in college who's dealing with the fact that they're starting to flunk out of school. They've been away from home the first time. Maybe they're from another country and they're dealing with, different foods that they're very uncomfortable with. Maybe they're dealing with a sexual orientation change or a revelation that's happening with them. All of these things can create huge emotional, weight on an individual. And so I need to find, how fragile are they, from that perspective as well. And then it's a simple matter of, exposing them to things as we move to more and more challenging activities.
Yeah, I think that's a really good way to really look at it, especially with first and foremost looking at ruling out anything really sinister that kind of says, is this something I should treat or not? And then kind of really gathering where the patient is on many different aspects, from physical, emotional, and all the other ones that you had mentioned, and then kind of progressing exercise dosage comparatively to help them reach their goals based on the limitations that they have. And something that I had learned, I'm going to ask this one off the script here, because something I had learned in school was kind of this topic and this concept of regional interdependence. So, and I was taught that, it's not usually a knee problem, it's usually a foot or an ankle thing. And I'm just kind of curious because that's what I was taught. I'm curious from your point of view, from you kind of really studying and researching the knee and also kind of being more heavily involved with sports, is what are your thoughts on regional interdependence in terms of how it can sometimes contribute to these situations, and kind of what does the evidence say on this?
I wrote a paper on that probably 8-9 years ago now. I mean, it didn't use the phrase regional interdependence, but just the idea that hip pain or that a hip problem may be causing somebody's knee pain. The reality is, first and foremost, things probably only move about one joint. So the hip could contribute to something at the knee, something in the knee could contribute to something at the foot could contribute to knee, but foot probably can't contribute up to the hip. And people would disagree with that, but honestly, the body's not that stupid, and it's going to figure things out at least one joint up from that for the most part. That being said, I actually find that that's probably, if that is a problem, it's usually the secondary problem when I'm assessing someone. Usually, the pain is, pretty focal, to the knee. And so the argument would be, like, for example, the role of the hip at the knee is, well, if they're going into internal rotation at the hip, that's encouraging valgus at the knee. The valgus at the knee is creating more contact pressure at the patellofemoral joint, and therefore we have patellofemoral joint pain. But when you actually look at the epidemiology and the way that these patients present, they often move with some sort of valgus already. They always have. They never had pain before. And then when you do your interventions and try to correct all these things, you track them out for a year or so. None of that actually changed their mechanics, and their symptoms are better, but they're still in their valgus. And so that kind of challenges that idea that it's strictly coming from that. So typically, if I'm going to use a regional interdependence type model, I'm going to use that as a way to temporarily reduce loads to an area. But then what it comes down to is that area needs to learn how to take the load that's going to be applied to it by that, potentially internally rotating hip. That's not to say I don't want hip strength. I mean, I want everything to be as strong as possible. I'm not of the mindset that we are smarter than somebody's body as far as how it's figured out how to move. There's some really interesting work with complex adaptive systems and dynamical systems theory and things like that could be a whole podcast in and of itself.
Oh, absolutely. And I think, you going back to kind of looking at the results in terms of like the pain and disability and how valgus hadn't really changed. And something I kind of want to get your thoughts on, because this is something I've been reading and we've had discussions in clinic, is that valgus does seem to be important, especially with maybe an athlete who's trying to land from a jump, especially for helping reduce risk of ACL. Is that something that you've kind of learned as well?
Yeah, also I've written a little bit about that too. But when I teach about the knee now, I actually I think the valgus is actually probably secondary to a lack of knee flexion at landing. And so when you look at a lot of those studies, what you'll see is that the technical phrase they'll use is that they lack an internal knee extension moment, which what that means is that they're not really putting much of a request into the quadricep. They're keeping their knee very, very stiff and landing with an almost straight knee. If you land with a straight knee, you're not going to be able to absorb shock very well. So what the body has to do is absorb that shock in some way. So either use a hip strategy, which is where, they'll fold over, bend really sharply at the hips to throw their shoulders forward. And if that doesn't take enough shock, then another way that you could absorb some of that impact would be by going into a little bit of internal rotation at the tibia and the femur. And to me, I think it's the problem is that the valgus is actually a output of a poor shock absorption strategy. So typically I'm less concerned with the valgus, especially if they're bending their knee very, very deeply. And again, people, you could try it to yourself. If you flex your knee to 90 degrees, go into valgus, you got tons of valgus you can go into. If you keep your knee at about 20 degrees, which is right around, I think the average around 23 degrees is the angle that people tear their ACL when they tear it. Put your knee at 20 degrees or so and try to go into valgus, and you'll feel there's not really any real motion there. And that's because, you got an ACL in the way. Again, what position we put the knee when we do a Lockman, we put it in about 20 to 30 degrees of flexion, and then there it is. There's the ACL. So the valgus definitely causes something like an ACL injury, but it probably is the straw breaking the camel's back more than it's the root cause in my mind.
Yeah, Erik, so just when you said something there about shock absorption, it just kind of made me think, what are your thoughts then on giving the athlete or anybody who plays maybe a jumping and landing sport, specifically females even, like a custom orthotic to help with that shock absorption? Do you think that would help decrease injury?
Yeah, you could. It's probably not going to, when you talk about it's factors of body weight is what we're talking about, the torques going around the joints when somebody's landing from a large, big movement or trying to running at full speed and trying to decelerate on one leg to make a cutting type move. I don't think that an insert is going to absorb enough shock. I think it would be a very small percentage of that total shock, going into the system. And there is, Ed Woitas, he's the editor of Sports Health Journal, actually very active in the American Orthopedic Society for Sports Medicine. He's a surgeon at University of Michigan. He's actually been looking at this idea that like an ACL tear is actually a cumulative injury, meaning that it's little micro traumas over time, and then eventually it will tear through. And so a lot of times it's not even, if you're absorbing shock kind of okay, it still may end up blowing out the ACL eventually. And I think Darren Padua has been looking at that as well. This idea of you can look on Twitter, this debate about fatigue, and some people talk about it as, the person is becoming fatigued. But some of these other people, Padua being one of them out of UNC, that'll talk about the ACL itself is fatiguing, and it's not so much the body.
That's really interesting, and I especially like your response to kind of all these, because this definitely helps clarify a few things for myself. And of course, we can go based on the best available evidence, as you kind of had mentioned before. But I'm going to kind of ask you kind of a broader question on this. So Erik, what are the limitations of all this evidence from these topics that we've talked about regarding the knee? And what are some of the big research questions and unknowns that we really still need further answers and studying in regards to some of these things going on at the knee?
Well, the problem with it's not really the problem. It's the problem with the evidence. It's the problem with the way people utilize the evidence. Is that people like to look at one study or one little cluster of studies and think that that's the end all be all, and that you can just answer something with one study. What I like to tell people is if one study changed everything about the way you practice, it's because you only read one study. It doesn't work like that. It's the totality of all the evidence. So how do we reconcile conflicting data? There has to be a way to reconcile it. Either one was collected poorly, or is there a hypothesis that actually explains both of these phenomena that we see? And so always taking a step back from the research and trying to look at it in its totality, and trying to make sense of it, as a whole. And it's one of the things that I think I know in the physicians world, they've made a huge strides in this direction of really pushing the how effective their systematic reviews are. So being able to do a true overview, and this is where we have services like Prospero, which do you actually have to register your systematic review before you conduct it with an entity like Prospero, so they can review your review and say, yes, it looks like you're accounting for everything here. Go ahead and conduct your review. And then you conduct that review, and it's fair and accurate. Because one of the problems with the older systematic reviews is somebody will say, you know what? I believe the world works a certain way. I'm going to find as many articles as I can find to support that view. And then I'm going to say it's a systematic review, and I'm going to publish that. So, and we've seen, you can look through especially the physical therapy literature, and you can find two systematic reviews that are looking at the exact same articles, and they come to completely different conclusions. And that's a problem. If they're set up and run properly, then that really should work a little bit better as far as getting everybody kind of on the same page.
Yeah, I think that's a big challenge in research, is getting, it seems like everything has very minimal effect size, or something, just a bunch of things disagree with with what other studies have shown. And, realizing that this question could probably be an entire podcast episode by itself, but why do you think those limitations in the research process exist? And what do you think the limitations of how research is being conducted and published are?
Well, and this is where we have the reproducibility crisis, which has happened in the psychology literature. And I would say our literature probably is very close with psychology literature, because it sounds like a lot of our interventions may have a large psychological effect. And where this actually stems from is the fact that research traditionally, I say traditionally, like over the last 20 years, has really gone down this road of setting itself up to create false positives very, very easily. And so there are things like tracking tons of variables. If you set up a sample size to look at one variable, and you say you have a p-value of 0.05, 0.05 says there's a 1 in 20 chance you're going to have a false positive. Well, if you then, with that same sample, look at 20 different variables, guess what you're going to find? A false positive. You're guaranteed. And so what these authors were doing is they would run an experiment like that, but then when they would publish the paper, they would just talk about the one thing that was positive. And then they would create a narrative around that positive finding, and then it would convince everybody that there's a thing going on here. The problem is when they go back to reproduce the paper, and this is hence the reproducibility crisis, turns out it's not an effect. It's not actually there because it was a false positive is what was originally found. So when they actually run a proper study to look directly at the one question, it kind of falls apart. And so that's where we end up with this kind of problem specifically in our world, where you can find a research paper to support anything you want to do. And that's not really ideally how research be done. So there are things that are going in place right now to try to control for this. The big thing is pretrial registration is one thing. So you have to lay out everything you're going to look at. You have to lay out exactly how you're going to do your data analysis. And then you put all your cards on the table, publish it, and then you go and conduct your experiment. And so then, somebody like me who's reviewing the paper, I can look at the paper that was submitted, and I can compare that and contrast that to the paper that was actually registered at pre-trial. And I go, well, wait a minute. It looks like you dropped 3 things that you had looked at. What did you find over there? Or why was that dropped? And you can challenge those authors in that way. The best thing is actually the register report, which is becoming more and more popular in the medical world and some of the other sciences as well, which is where you actually design your entire study and you submit it for review for reviewers to say, actually, you need to change your statistical analysis to this. You need to increase your sample size to this number here. And you need to make sure you control for that right there. If you do all these things, we're going to go ahead and approve this paper and accept it for publication, even though you haven't even conducted the study yet. And the point being is whatever you find, it will be accurate. So if it finds negative finding, finds a positive finding, we're going to see it as face value, because if you're controlling it as well as you say you're controlling it, this is a high quality piece of research.
Yeah, Eric, so that being said, what journals and resources have you found to be both, credible and reliable when it comes to physical therapy research?
Well, for physical therapy research, it's tough. I will say British Journal of Sports Medicine has been doing a really good job lately with their systematic reviews. They've been using Prospero, I mentioned them before, and making sure that they're pre-registered and conducted well. There's been some pretty good things in there. That said, every journal has its issues, and you can always find a bad article in just about any journal. JOSBT has been trying. They've had problems in the past. They are trying to get better. They have a new editor now with Claire Ardan. And I'm really interested to see what she does with that journal as well. I also know International Journal of Sports Physical Therapy has recognized that they have a problem, and they are working right now on correcting that problem. And that's the current board of the sports section is working closely with the editors. Just had some conversations with those editors a couple weeks ago at the AOSSM meeting, and how they're really systematically trying to move everything forward, get the reviewers to have a better understanding of how to review an article. As my resource, typically, I really enjoy the American Journal of Sports Medicine. It's not a physical therapy journal. It's put on by orthopedic surgeons. The American Orthopedic Society for Sports Medicine is the lead with that. Bruce Ryder has been the editor of that for well over a decade now. You'll notice every article in there is pretrial registered. You'll notice lots of dialogue and conversation within the articles. I've been to their reviewers meeting, and how they have a statistician that will actually walk them through the statistical analysis. And so the reviewers are really top notch. Again, as I just said, you can always cherry pick individual papers out of a journal that slip through the cracks. But I really like what American Journal of Sports Medicine.
So, Eric, I think it's really interesting to kind of get that perspectives on big name journals and organizations that are putting out research, and kind of how they're looking to improve by implementing some various kind of checklists and kind of some checks and balances in there to kind of work on that. And something else I know there's been a big push for clinicians to utilize is, of course, as we know, the clinical practice guidelines. But let's get some context first on this. How were the clinical practice guidelines formulated, and what are the pros and cons of using these guidelines?
Well, I'm a big fan of the idea of clinical guidelines, practice guidelines. I think that really is and that's been something they've tried to implement. All 20 years I've been practicing, there's been efforts to go that direction. But the problem that we have is, as I just mentioned, like with the reproducibility crisis, is that you can find research that can support just about anything. And so when you're looking at the totality of the research, it can be really tricky when you develop a guideline. And that's because my friend JW Matheson, who I do PT Inquest with, he's been involved with a couple of those and been like in the room helping to design them. And basically what it comes down to is you have like 20 people that are sitting in a room and they kind of all vote almost. They come down to, what they want to see in there. And then you'll see a lot of times there's just not a lot of really good research to support anything. And so they just kind of go with what they like, and then they kind of can bicker about what grade they're going to give what. And it's interesting, like in like in the surgeon's world, they talk a lot about a financial conflict of interest. In our world, we have intellectual conflicts of interest, meaning that, somebody may have spent their entire 20 years of practice, 30 years of practice, 50 years of practice on one very particular view of how the body works. They may have had extensive training and very specific interventions that it turns out there may not be a ton of evidence for, but because they've invested so much of their time and knowledge to this these concepts, they'll have a hard time looking at literature in an unbiased way. And so they can really start pushing, almost a little bit of an agenda. And I know you had Adam Meakins on lately, and he's gotten some flack for this, where he's talked about some of these people that have a lot more like cachet. They've been around for a long time. They've paid their dues, but a lot of times they have very old and outdated and actually not very well supported views on things. But out of quote unquote respect, we let them have a platform and we let them, get followers, and then we let them, they're on clinical practice guidelines and they kind of exert their will on things. And it's almost one of those things that, you kind of wait by attrition. I think it was Richard Thaler, who's the recent Nobel Prize winner for economics. He commented, somebody asked him about changing people's minds. He goes, "Oh, I don't think I've changed anybody's mind. I think my focus has been to corrupt the youth." And that's been kind of my view to things as well, is I don't try to go to the higher ups or whatever and try to wrestle with them and convince them to change the way they're practicing and change the way they see the world, but just let attrition just kind of move them along and just really focus on getting, the people who are coming up to have, better critical thinking skills and to have a much better comfort zone with uncertainty and to be a little more fluid in the way that they see things.
Yeah, I think that's a really good point, because, one of the things that I think noticed as far as clinical practice guidelines is, you do have kind of the wide array of experience versus specialty versus research versus clinician. And I think that all those viewpoints are really important, especially as far as the historical perspective goes. And I really like that quotation that you talked about, how you want to corrupt, or how he wants to corrupt the youth. I think that's a great quotation. Speaking of corrupting the youth, one of the things that one of the people that have a very high influence on new physical therapists are DPT program directors, DPT educators. They really have a huge influence on how physical therapy is going to be, 10 years from now, 5 years from now, 20 years from now. If you could say one thing to DPT educators and program directors, what would you say to them?
I think we need to do a little better job with teaching critical thinking as its own thing. And that's not just, with the educators in the academic setting, but I remember when I was coming out, they would talk about, there was a study that had come out in the late 90s that said that physical therapists tend to practice most like their last CI. Whoever their last clinical instructor was, they're going to basically just mimic that on through. And so that's one of those things that, as a CI as well, that I'm always really pushing on our interns is, I don't want you to practice like I do. I want you to be a good critical thinker when you're done. Because ideally in 5 years, I'm not going to be practicing this way anymore. I'm going to have evolved, and I would hope that you would as well. And that's that whole process of critical thinking. And this is where, there's a local here in Portland physician that's made a little bit of a name for himself of really getting out the nuance of research. Dr. Vinay Prasad, who's an oncologist, and he wrote an article, it's about 8 years ago now, where he was encouraging the schools to teach, he called it encounter-based medicine. And actually, I think it's an open source article that anybody can read at this point. But kind of the point being is that a lot of times, new professionals come out of school and they have a bunch of facts shoved in their head, but they don't have any way to actually use them. They don't have that template, that model to move forward with. And so the idea there is if you're teaching from the perspective of the encounter, meaning, okay, patient walks in, what are you going to do? Patient starts saying this. How are you going to bring in the evidence into this conversation? How are you bringing the evidence into this interaction? Are you pulling one-off articles out of your head and then applying them, kind of cherry picking them? Or are you thinking as the totality of this individual in front of you, the objective truths that we have out of the literature, and these are the kind of the quote unquote inarguable facts, and then you have the subjective reality of the patient in front of you. What are they dealing with? What's their cultural background? What's their history? What's their social structure around them? All these other things that have huge input on what this interaction is going to be. And how can you best use the evidence to make the biggest change for this person in the direction that they want to go? But that's, again, not, I've been critical of things like the PICO question, but the idea there is that you're going to find, by using that process, you're going to go out and find the exact article that is a perfectly well-conducted randomized controlled trial on this exact population with this exact diagnosis at this exact point in its timeline, and have concrete evidence to give you a clear-cut answer as to what you're going to do with this patient. It's just not how the evidence works. The evidence is basically just a slew of probabilities, People fall into risk categories. They fall into potential benefit categories. It's another thing I see in physical therapy that I think we should do a better job of preparing new grads to understand that not everything works and that not every patient's going to get better. We see this all the time, where I always have our interns go shadow an orthopedic surgeon and listen to how many times the orthopedic surgeon just looks at a patient and goes, I can't help you. I don't know what's going on with this, but I can definitely make this worse. And so I'm going to say, I can't help you. Or somebody that he or she did work with, and at the end they're sitting there going, the outcome isn't exactly what we were hoping for. And that is what it is. I deal with this in sports medicine all the time, that somebody gets an injury and it's like, the likelihood this person is going to come back from this is almost zero. But too many times I see physical therapists just insist that there has to be a perfect answer. There has to be a perfect intervention. And if this patient does not do perfectly, it's because of, my own personal failure of not being able to find the exact little tool. And so we tend to throw more and more things into our toolboxes. So, but again, that process of critical thinking, being able to constantly ask yourself how else you could explain things that you see in the world, I think would be real valuable.
Yeah, I think those are some really key points, especially to bring up regarding the educational process. Like you said, critical thinking, teaching them how to apply the evidence in these situations, being okay with kind of uncertainty with certain situations as they're not always clear. Of course, accepting of the fact that we're not able to help everyone, and that things are just not perfect and ideal all the time. So I think those are some very, very key important take-homes that I think educators, program directors, and students should hear. But now I kind of want to flip the script a little bit and kind of ask a similar question, but to a different audience. So, of course, as we know, Eric, with all DPT programs, they also have influences in what they do from the accreditation board, so CAPTE. So my follow-up to this is that if you could say one thing to CAPTE, or anyone who's working within CAPTE, what would you say?
I would like to see, when accrediting a program, I would like to see that as a standardized part of the program is critical thinking and science application. And I almost would like to see it as an introductory course and then also as a finishing course, almost the same course. Because you probably remember it when you're in PT school and you go through a course early in your process, and then towards the end you'll be looking through that old textbook from old being 2 years old, looking through that old textbook or those old documents, old tests even, and being like, wow, this is so much more interesting now that I have some sort of understanding what's going on, and holy crap, there's a lot here to learn. I mean, in the course I do a biomechanics part that's, I mean, it's literally the most basic of biomechanics, and it blows everybody's mind. And it's like, you had this in school. But that idea of, as part of the accreditation process, that schools have to show some sort of critical thinking process. A lot of schools were doing clinical thinking, but that's not what I'm talking about. Critical thinking is this very specific process of how somebody goes about interacting with information, basically. And I think that's something that I think would do our profession a good service to establish that in our new professionals.
So we've talked about CAPTE. Now let's talk about FSBPT. So that's the United States board that prepares and administers the National Physical Therapy exam here in the U.S. If you could say anything to them, what would you say?
That's a little harder question because, when you're talking the initial licensure, it's interesting. And again, not that I've taken that exam recently. It's been 20 years or so, but I remember some very obscure questions. And I'm just like, I don't even know why. I don't know how this applies to anything, or if it's even validated, some of the questions that are on there. You could argue whether it's important to know the nuance of using an ultrasound machine for therapeutic ultrasound, but it'll be on the test anyway. I think I would like to see, I'm biased from a sports medicine perspective. I'm sitting there taking a license exam. I don't see any sports medicine questions on there. All I see is a bunch of questions about like acute care, maybe like a manual therapy type thing. That'll be about as close as it gets to actually the sports medicine world. Why do I need to know details about particular lobes of the lung but for some reason a pulmonary therapist doesn't need to know proper sideline management of a concussion? This is where it gets into how much specialty training should be in an exam like that. What is really the core parts of being a physical therapist? I've heard it be argued that the main thing physical therapists really deal with is actually a biomechanical modeling of dynamics and statics. And that should be like the really heavy part of that. And people think, oh, well, but biomechanics don't matter necessarily, like where the knee is in space. It's like biomechanics refers to the human body's interaction with the outside world. So the way water moves up and down a plant stalk, that's biomechanics. The way the cardiovascular system works is biomechanics. Nerve conduction is biomechanics. All these things are biomechanics. And that those kind of root core principles should be what's more established. And then I would also like to see exercise prescription. That was something we were talking about before we were recording, is how it's shocking how poorly a lot of physical therapists are prepared to dose exercise, even from fairly basic parameters. I see it in the continuing education world when I'm teaching courses to people who are already graduated, but I hear this also from professors too, where they're like, yeah, it's something that just isn't really being covered. And a lot of times, a group like, that's doing like a credit, or that's doing licensure exam, a lot of schools are teaching to the exam. So if that was more heavily placed into the exam, schools would be forced to prepare their students to be doing that. I think that would be a useful component as well.
I think that's a really interesting take. And to kind of take it one next level of that, how do you think is the best way that actually happens?
Honestly, I don't know what that process is. I know I've been involved with board certification. So for like the becoming board certified in sports and seeing how that process is, it is a monster task to add a question. The little insight I can give, and every specialty operates theirs differently, but I can say from the sports section side, if I write a question, I have to write a vignette, and then I'll write like 3 questions that apply to that vignette. Each question then has a multiple choice answer. They have to be able to answer the question without choosing from something. So you can't say, of the below, which one would apply? You have to be able to be a fill in the blank type thing. You can't have the questions build on each other, meaning that if you got the first one wrong, it doesn't mean you automatically get the second and third one wrong. And then the final thing, this is the most fascinating thing, not only do you need a citation for the correct answer, you need citations for each incorrect answer that you can actually point to say, here are the citations that show that this answer is incorrect right here and this answer is incorrect right there. So that's a huge undertaking just to write a couple of test questions. And again, that's from board's specialty. I can imagine from, the actual, licensure exam being quite the animal.
Sure. And then especially getting at the fact like we were talking about earlier about how the research really can be so biased in these different avenues. And that definitely plays part too.
Absolutely.
You had mentioned, Eric, about how there are some programs that teach the exam. Let's pretend for a second that that's not happening. Let's pretend that, and realizing obviously that there are CAPTE requirements that need to be met in order to facilitate passing scores on the NPTE. But let's just pretend there's no requirements, there's no board exam. Programs don't have to teach to anything specific. If you could create your own DPT curriculum or post-professional path without having to worry about any of that red tape, what would your ideal program look like for DPT?
Well, there would be a heavy base of critical thinking, as I mentioned before. We would also have a heavy study in empathy and theory of mind. So, most people understand empathy, the ability to understand how somebody else is feeling about something. Theory of mind, the understanding that the person opposite you has a brain that functions and there's a human that's in there and it has its own kind of thought process. That's something that I think Stony Brook University is doing that with Alan Alda, the actor that was on MASH. He kind of has spearheaded this of trying to get scientists and healthcare professionals to have a better understanding of empathy and theory of mind, because a lot of this gets into that interaction with the patient, which is so important to establish. And then laying out a very firm base in biomechanics. And again, getting away from the idea of the sub-branch of biomechanics most people mistake for biomechanics is kinematics, and how it's so much more than that. And then layering on top from there. I mean, when I went to school, we didn't have manual therapy as part of our curriculum, and the viewpoint was it was not a base core concept. It was something that you would do on your own by doing continuing education. It's something that the base core concepts were the underlying principles that manual therapy would be built upon, but it wasn't something that was necessarily there. And so, my feeling would be a very heavy exercise base, establishing that. And again, we're talking entry-level practice. This is the interesting thing where you look at physicians. A physician finishes medical school, they get their MD, they can't go practice. They are just starting their learning process. They take their licensure exam just to be able to go and do an internship, basically. And they do their internships and their residencies in that way. So I honestly don't know that we have that extensive of a knowledge base that's required for that. But it is interesting, this idea that you got to learn everything in school, which really you just need to learn how to learn.
I think that's a really powerful point, and I think that that's definitely a theme that has come up in quite a few episodes throughout the podcast, is really teaching that learner to be adaptive and learn the fundamentals to be able to apply a lot of these things and critically analyze what's going on and continue to evolve, and really how to navigate these unfamiliar and uncertain situations. So I think those are some really good points in there, Eric. And, I know you and Adam both have a course coming up in Washington, D.C. on September from the 22nd to the 23rd of 2018. Do you think you could tell our listeners a little bit more about what you'll be covering at this course? I know you kind of alluded to some of it earlier and kind of throughout the podcast thus far.
Yeah, so I have a 2-day hip and knee course that I normally do on my own. Adam has a 2-day shoulder course that he does on his own. We've teamed up a couple times, mainly because I guess your listeners, if they heard Adam, and I haven't heard Adam's interview, but I'm sure it's entertaining because that's just the way Adam is. And so Adam and I have a lot of fun doing things together. We do a podcast together as well. And we have similar personalities in some ways, but very different in other ways. And it's fun to kind of play off each other doing the presentations like that. So what we've done is to do something just together from time to time, we do a course where he does a day of shoulder, and then I do a day on the knee. We both talk about critical thinking. I talk about application of evidence in medicine and that process. He goes into really simplifying and breaking the way you approach a shoulder into a couple of very simple categories, and thinking of them in categories instead of trying to kind of nitpick things too much. And then, he wraps that up with some interventions, mostly around exercise with it. And then my course is, we talk dynamical systems theory, which also complex adaptive systems, changing movement, whether you can or can't, which of course there's not a black and white answer to that either. We go into biomechanics around the knee, why certain force profiles are required as for function, how to test those types of things, and then we look at interventions. And so the main 3 points I try to get people to understand from my course is human movement is insanely complex, driven by an insanely complex nervous system. Constraints on the system can create problems. We can use things like dynamometers, basic biomechanical modeling, to look at how those constraints can create that. And I'm not talking about stuck joints. I'm talking about force production, because some people are like, oh, so we're talking about that? No. And then going into how do we take somebody from where they are to where they need to be with a progressive loading program. And again, it all comes down to understanding the underlying root problem that you're trying to address, and you address it directly.
Yeah, that seems to make a lot of sense, Erik. And, we usually like to ask this last question to the end of our episode to each of our guests. And the question is, if you could change one aspect of healthcare education, whether that be DPT or other healthcare provider related, which aspect would you change, and how would you change it?
Back to the idea of uncertainty, that, science is founded in this idea that you cannot know anything to be absolutely true. You can prove that things are false, and that's a falsifiability concept, but you can't prove that something is true. This idea that I see too many people coming out with is that there is a black and white answer, and it's going to be the clear-cut answer. It's like, no, you're always basically trying to go halfway there, and you're always halfway to that line, but you'll never meet that line. You just get closer and closer and closer. And so I'd love to see people come out with a lot less certainty and a lot more kind of fluidity of mind.
Well, that's great insight, Erik. And, thank you so much for joining us today. It's been an awesome podcast with you. It was awesome to compare what your statements are to what Adam is saying. I think that our listeners will be very interested in hearing the two podcasts. If people want to reach out to you, Erik, where can people find you online?
The easiest way is just to go on the website I do for professional development type things, and that's thesciencept.com. So you write out thesciencept.com. And pretty much everything is there, links to all the stuff I do. Twitter is the only social media I really interact with, and that's like maybe once a day, every 2 days or so. And that's at Erik Meira, which again is linked on that as well. Those are probably the easiest ways.
Wonderful.
Perfect. And all those links will be in the show notes, guys, if you guys want to kind of check that out. And, Erik, again, thank you so much for your time, your dedication to the profession. It's always a pleasure.
All right. Thank you.
Hey, everybody. Thank you for listening to the Healthcare Education Transformation Podcast, as we greatly appreciate your support to help us advance healthcare education. We are very happy to announce that we have created a new tool to help develop clinicians into better experts. With that being said, we have created the HET Light tool, which LIGHT stands for Learning Integrated Towards Expertise. And what we've done is we've taken our first year's worth of episodes with experts in the fields of healthcare and education, and we've taken one golden nugget or theory on expertise and presented it to you in a very easily consumable format, so that people can take one lesson or nugget per week and map out and plan how to incorporate it into your clinical and educational practices. And by the end of the year, we think you'll be pleasantly surprised at how far you've progressed towards becoming an expert. To find out more, please check it out at pteducator.com/HET, which is also available in our show notes. Thank you again all for your continued support. Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.